Hello, I am Dr. Joshua Zaritsky, Chief of Pediatric Nephrology at AI DuPont Hospital for Children in Wilmington, Delaware, and today I'll be giving you a talk on Pediatric UTI update in 2019. What is a clinician to do? So I'll just briefly review in the time I have some of the AAP guidelines that have come out and which have really are here to stay. It covers the diagnosis of management of UTIs, specifically ages 2 months to 24 months, and that's where we have the most data. We recognize the prevalence is fairly high. And just remember that these AAP guidelines are considered for sort of our healthy, run-of-the-mill children, not children with any anatomical or neurological abnormalities. So the first thing that the AAP wants you to consider is that if you're going to treat a child with antibiotics or antimicrobial therapy, is a urine culture needs to be obtained, and there's only 2 ways to do it. One, a suprapubic tap, which is considered the gold standard, but unfortunately perceived as unacceptably invasive. The other is catheterization, which admittedly has a very high sensitivity and specificity. I'll just put a plug out there to say bags really need to be avoided, specifically for urinary culture. They just have too high a false positive rate. If we take the overall prevalence of 5% of a febrile UTI being out there and we do a bag, it gives us a false positive rate of 88%. That goes all the way up to a false positive rate of 99% for circumcised males. So bags, no good for urine culture. The diagnosis, the AAP wants you to do a UA, which is positive, and a culture. Those two have to go together. And that's to recognize the fact that a UA is very sensitive but not always 100% specific. And I've included here some of the ideas of what a good urinalysis is. Urine culture results as well, the AAP changed some things where they lowered the definition of a UTI from 100,000 to 50,000. Obviously this increases sensitivity, likely at the cost of decreasing specificity, but it's really needed for children who have lower bladder incubation times. This is countered by the UTI criteria, which now includes pyuria. So you're able to now effectively rule out asymptomatic bacteriuria. That is, you get a UA that's completely negative. You have a positive, the culture grows something out, but the UA is positive. We tend to put those patients into asymptomatic bacteriuria. Moving on, the treatment route here is practically driven. And so really you have to look at your local antimicrobial sensitivity patterns. And I put in there in parentheses, get used to it, because that's what your ID doctor is going to say to help pick what drugs you're going to use. Treatment duration is pick a football score 7 to 14. The next thing is all small children with a febrile UTI should have a renal/bladder ultrasound. That's an action statement. And that's just to remind me to tell you that no more imaging, especially a VCUG, is needed according to the AAP unless an abnormality is identified by the ultrasound. So we've seen the pendulum swing from doing VCUGs on everybody now to almost never doing VCUGs. And there's this new focus the AAP wants you to take, is that we want to make a rapid diagnosis and get those kids treated early, regardless of the degree of VUR or vesicular ureteral reflux they have or prophylaxis. And after the first UTI, what they want you to do is instruct the caregivers to be on the lookout for another UTI and to seek a prompt evaluation with a future febrile illness. And here's another shift, no more routine prophylaxis. The evidence, depending on what study you're going to use, the AAP used 5 studies and did a meta-analysis of them. They did not have the RIVER results available at the time. That was another randomized double-blinded controlled trial which showed a positive benefit of prophylaxis. But here the AAP says no more prophylaxis. And then you're left, of course, as the clinician, what to do. Do you stick with the AAP guidelines? Do you go back to doing VCGs? I think most of us out there practically hope that when the pendulum has swung all the way to one end, it will swing back. But you have to recognize here that individualization is the way to go. And this idea of precision medicine, it can mean fancy blood tests, it can mean genetics, but it can also mean treating your patient as an individual. And I've included there just the reflux grades seen in the RIVER trial to remind you that they had reflux, obviously, but look at the changes after 2 years. 75% after 2 years were either resolved or better. So question into the utility of a VCUG to pick up reflux when it's only going to disappear by itself later on. I'd like to thank you for this opportunity to give you an update on the evaluation of febrile UTIs in 2019. Thank you.